Well, I'm Rachel. I'm the chair and co-founder of the Long COVID Collective, and we are so excited to have you, Dr. Brode, as our first LCC podcast guest. So welcome.
Thank you. Thanks for having me.
So tell us a little bit about your role and what you do for the clinic here.
Yeah, so I'm Mike Brode. I'm a general internist, so take care of adults with all medical problems, and I'm faculty here at the medical school, Del Med, at the University of Texas at Austin, and I am the medical director of our post-COVID program at UT Health Austin. So a little bit of everything. I do take care of patients with long COVID, do research in this space, and also educating students, doctors about the condition.
Great. And how did you get into working with people with long COVID or COVID in general?
Yeah, starting your career, I didn't think, long COVID is going to be my job. I actually got into it. I was actually brand new as an attending physician, so just finishing all my training. I did a year of chief resident of global health in Kenya and then came to Austin right in the end of 2019. And I thought, I'm going to take a nice vacation in April 2020. So I ended up working 24 days in a row in March 2020 in the hospital. And as you imagine, that actually put me in the center of our COVID-19 pandemic preparedness. I was the doctor deciding who got a COVID test or not. And at the end of those days, the vacation didn't happen, but they asked me to continue in a role to really help coordinate and lead our hospital response. So I kind of learned a lot about taking care of COVID in the hospital. We created some community health worker programs to help the transition out of the hospital and meet people's health-related social needs. And that kind of all came together by the end of 2020 when the leadership decided we should really start a post-COVID program. We were initially thinking it was going to be primarily for people transitioning from the hospital, and maybe the people who were not hospitalized having all these weird symptoms would be a small subset. So they asked me to take that knowledge of COVID in the hospital and start the post-COVID program. As we started to set up the program, we realized, that's not where the need is. Most people with long COVID are not hospitalized. So we did a pivot there, but I think kind of engaging with the patient community, like seeing these patients and really kind of being interested of what is this illness and being on the leading edge really propelled me to continue it and enter this space, taking care of patients and doing research.
Yeah, definitely. That's so interesting. Definitely a career plot twist there. But so you said obviously most patients, or a lot of them, don't have severe COVID cases, acute infections. So what does qualify as someone having long COVID? What kind of diagnostics are used to diagnose that?
Yeah, I'm going to answer that a little bit differently because I think most people start with, there are 200 symptoms and 10 organ systems. And I think that was really groundbreaking research. But there's this thought out there of long COVID is everything, therefore it's nothing. And in my experience, I kind of want to start the opposite. And describing what 95 or most long COVID is. And I'd say fundamentally, long COVID, in my experience, is a post-viral chronic fatigue syndrome, really characterized by fatigue, brain fog, and I think one of the essential features is that post-exertional malaise, that crashing phenomenon. Mm-hmm. And that chronic fatigue can come with or without problems of the nervous system, usually the autonomic nervous system that controls heart rate, blood pressure, temperature regulation. It's been my experience that most of the times I can trace back people's symptoms to either their fatigue, problem generating energy, or problems of their autonomic nervous system. Mm. I don't think that captures every single thing that can happen after long COVID, but I like to stay of like, this is what it is for most people. The scientist in me would also say though, of course, the COVID infection can cause other health problems. People who are sick enough to be in the hospital on the ventilator can have lung scarring, kidney disease. And it's very clear too that the infection can increase the risk of developing new chronic conditions, type 2 diabetes, blood clots, stroke, or even autoimmune disorders. But those things we can kind of traditionally detect on our tests and have evidence-based treatments for, whereas long COVID, kind of that post-viral chronic fatigue, neuroinflammatory syndrome, we still do not have a diagnostic test for. And so in clinic, what we're really trying to do is establish, do you fit this pattern? Do you have the typical symptoms? Did it start after COVID infection or an infection that looks like that was probably COVID? And is there obviously not something else going on, is how we make that diagnosis.
Sure. So you mentioned some of like the main symptoms. A lot of people with the symptoms you said feel very like misunderstood because they don't always present as looking ill, or they're kind of invisible symptoms. So can you maybe address that and also talk about like what are kind of the biological, like how the virus impacts those systems, the autonomic nervous system and everything else, the fatigue that you were talking about on like a biological level?
Yeah, I think it's hard because most people, like when you're saying like the most common symptom is fatigue, it's one of those like everybody has felt fatigue in their life. And when is fatigue of just like you're tired, you're not feeling up for it, versus like, no, this is an illness. There's something wrong with my body. I do think sometimes, as I explain to other people, like it's easier to explain like the obvious ends. Like we're at the University of Texas, we have Division I college athletes who are in our clinic, and they just push through, they keep going. Their only way of coping is to try harder. And if they have long COVID, like that doesn't work. Like they are fatigued, they push, they experience the post-exertional malaise, and they can describe it. It's not like my muscles are sore. It's like, no, there is something wrong with my body. And it's very easy for a D1 athlete to describe that. But if other people have other medical problems, they come from backgrounds where they may not be believed, that gets really harder. And so I think it is a fundamental challenge. But I think for me, like you hear thousands of people describe the same symptoms and you're like, oh, there is something to this. They all didn't just get together and make this up. I mean, we think this disease affects at least 15 million Americans.
Sure, absolutely. So talking about like that stigma that, a lot of people don't understand the differences between the symptoms and what's normal, what's not. Like, how do you guys address that here? Like the stigma that's out there, both with your colleagues, other doctors, or patients themselves?
Yeah, I think we start by listening. And so we want people to tell their stories. We are lucky. We've heard lots of stories, so we can say like, hey, yes, this fits the pattern clearly of what we've seen. Or in some cases, we're like, you know what, this is a little weird. Let's dig a little deeper. Let's think about other things. And I think it's nice having that experience of hearing all those stories to be able to do that. A lot of other doctors don't. And it's hard. I think I've grown a little bit disappointed with other doctors not interested in or having compassion, empathy, or curiosity to explore something that was not in the medical textbooks. This is long COVID has only been here for 5 years. But I really implore them to listen to the story. Clearly, this is happening at a scale affecting millions of people, and learn a little bit deeper. As you said, I do think we don't have the full mechanism understood, but at least the broad outlines of what is happening on the cellular or biologic level is really starting to emerge. And I think it's an exciting time, actually.
Yeah, absolutely. Well, that's encouraging to hear. I'm sure it'll only get better with time as the research goes on. But talking about how obviously it's so broad, the spectrum of what people go through, and a lot of people like myself and so many others in our group go to 20 different doctors because nobody either is listening to them, like you said, they're not understood, they refer them from specialist to specialist. So kind of what's the role of the post-COVID clinic here, and how do you create a treatment plan or a management plan for the patients?
Yeah, I think there's a couple different models. We actually kind of switched up because of that exact experience. Some models are like, oh, you see one doctor and then we're going to send you to 5 more. Mm-hmm. And as we gained experience, we realized, once again, a lot of these symptoms are actually connected to one another. Mm-hmm. The brain fog is clearly connected to the fatigue. People who have nerve pain, it's usually connected to other symptoms of their autonomic nervous system, like gut problems, gut motility. And so we tried to really think about that holistically. If something was like really severe or strange, we should send them to a specialist. But yeah, our fundamental treatment approach still involves, I would say, 4 steps. The first is really making sure people are pacing, that they're managing their energy, that they are not experiencing post-exertional malaise, that crashing makes people worse. For some people, doing that well gives their body a chance to heal, and that can be really impactful. The rest of the steps, step 2, trying to get people doing rehab, like for physical, cognitive, emotional, whatever drains that body battery. The goal is to kind of push that wall a little bit farther away. Those things aren't always curative, but they can help. But if people are really severely disabled or not getting to where they want to be with those first 2 steps, we'll move into medications to treat usually specific symptoms, whether it's fatigue, nerve pain, insomnia. Yeah, we prescribe medications. We've got lots of tools in that toolbox. And then the last step, if that's not getting where people want to be, we'll try some of the more experimental stuff, the things that we hope someday will be step 1 of curing the underlying disease. But experimental means that usually that we don't know if it will work or if it will work for all patients with long COVID. And unfortunately, the hard conversation we have is a lot of those experimental treatments are just not going to be covered by insurance. So even the exciting things we want to try can be limited purely based on people's able to access them.
Sure. What are some treatments or research that you guys are kind of maybe hoping to work on or that you've worked on recently that gives you encouragement about what the possibilities are?
Yeah, I think, so right now, I think it's emerging what the targets are going to be or what's happening with long COVID on the cellular level. I would say it's pretty clear that the virus triggers chronic inflammation, which causes the immune system to go haywire and start attacking or disrupting the smallest blood vessels in the body and the neurons that run with them. So I think what that means is, when the immune system attacks the small vessels and the neurons, you have problems generating energy and that neurologic signaling, once again, the fatigue and autonomic problems. I think what's missing on that is what is causing that chronic inflammation. Are there viral remnants, reactivated viruses, or is this autoimmune that, the virus tricked the body into attacking itself and it never turned off? And what's happening on the cellular level? Are there microclots? What does that damage to the small vessels look like? But within that, I think we're looking at targets on each part of that pathway. I would say the holy grail is eliminating those viral remnants. I'm a little bit skeptical of that because at least our existing antivirals have not shown any benefit. But I'm particularly excited about the treatments coming up to treat this a little bit more like an autoimmune disorder. I know they're trying a medication for lupus, an autoimmune drug called baricitinib that's expanding in clinical trials around the country. We are looking at medications that affect the neurotransmitters or decrease neurologic inflammation. We have a small pilot study of ketamine, which some patients have told me have worked, but we want to make sure it's safe and used appropriately. I know other big trials are starting. I'm very excited about the medications for the GLP-1 receptor agonists like Ozempic, Zepbound. That's a big trial coming out, really targeting that inflammation on the smallest blood vessels. So I'm hoping as it evolves, we'll have targets all along that pathway. But I think I'm most excited. I see a lot of it comes down to the inflammation and immune dysregulation, especially if people have the most severe symptoms. So I'm excited about all of it, but most closely following that space.
Definitely. And I know you're also doing some work with AI and stuff like that. So what do you kind of see the role of AI or any kind of, artificial intelligence helping with both long COVID treatment, management, symptom tracking into the future?
Yeah, I think I have both excitement and reservations about AI. I think what we are seeing, especially, the main challenges of just 15 million people with this illness and a lot of doctors who want nothing to do with caring for this illness. So my specific research is building trustworthy AI chatbot tools where you can get good evidence-based information on how to care for long COVID. And that's hard because there's a ton of information and misinformation out there. And so I'm working with researchers and computer science specialists and AI of how do we constrain it to what we think is the best information about long COVID, and how can we make sure it's ready for use, that we're actually evaluating, not just saying, have at it. We want it to be safe. My goal, though, is that if we're going to make these powerful tools and put them in the hands of clinicians, we should also put them in the hands of patients, like the people who could use it the most. I think people get pretty good answers from ChatGPT. It's better than Dr. Google, it's better than WebMD, and it is contextualized, but I think having a trustworthy source they can go to get good information is going to be really important, and we want to also really make sure we do that safely and don't put a lot of parameters around it so it is used appropriately or it doesn't answer questions outside its lane.
Sure.
So really excited about being able to expand access to care with the best available quality knowledge using these tools.
Absolutely. Yeah. It's so important. And I know that's something that we at the collective are also trying to play around with, is in the future, how to have some sort of curated AI system that it'd be more for obviously symptom management, like support systems and stuff, but so important. And I know a lot of people obviously look to AI for those kind of answers, especially when you have long COVID and you can't spend hours reading through articles and stuff like that. So going back a little bit with new research opportunities and stuff, I know there have been some federal changes. So are you guys experiencing any challenges as far as funding for that research or for the clinic in general, or any kind of general challenges that you guys are facing right now?
Yeah, I think, as I said, the disease has COVID in the name, so we're not oblivious to, I think that was such a trying and turbulent part of our history, and it's not really history yet. But people really want to move on. The association with those battles is hard to talk about. But in a weird way, I've actually been encouraged. I think it was back in March on a Thursday afternoon, they said, we're eliminating all long COVID research funding. And by Friday morning, they said, just kidding, we're going to continue it. And I think it just, from the realization, long COVID doesn't care what your political affiliations are. This is affecting about 3 to 5% of people every time you get infected. And it doesn't care if you wore a mask or not. So I think a little bit of it is affecting a wide swath of people. It is a chronic disease affecting millions. And I think there was just a fundamental realization, we should deal with this. And that is apolitical. And I think that has been encouraging, that the research has continued, and hopefully the big studies in the NIH have not been hugely affected by the budget cuts. I think it's affecting all the research apparatus, but has not seen a devastating hit to long COVID. And so we're plowing forward, we're not giving up. But I also, another think there's going to have to be other sources besides the NIH. I'm once again excited about that. GLP-1, the Scripps study, they got private funding to do a very large, very good trial. And I think they're doing it efficiently by centralizing it and doing it by telehealth. I think that's a model we need to do.
Sure.
and sites have done it in smaller, but this is a real big one. 1,000 people that we should really look to as a model for the future. So I'm excited. And then two, as soon as we develop biomarkers, I do think a lot of pharmaceutical companies are going to jump into this space once we figure out the underlying science. They're very risk averse right now. I can explain why that is, but I do think once the underlying science is better understood, pharmaceutical companies will invest in trying their treatments in it.
Absolutely. Yeah. Well, that's so interesting. And I'm glad to hear you're optimistic about it, because I know a lot of people are concerned and just wondering if the research is going to continue or whatnot. So on the same idea, can you talk a little bit? You mentioned that 3 to 5% of all people who get infected, reinfected, may go on to develop long COVID. So what is the role of both vaccination, reinfection, and then also talking about, there was a change in CDC policy earlier this year about recommendations for the COVID boosters. And I know that people were concerned, especially for youth, which a recent Lancet study about the role of long COVID in youth that may be a little bit undocumented. So what do you kind of see as all that?
Yeah, I try to be really thoughtful and reasonable about this, but it is, I think, for long COVID, it's very clear. Like, the risk of developing long COVID from having a COVID infection is about 7 to 10% every time you get infected. With vaccination, it reduces that risk by half, maybe 3 to 5%. So it helps a lot. And is our most effective tool, but does not eliminate the risk. And with reinfection, it's cumulative. So let's take that. If you have a 3% risk on the lower side and you've been infected 5 times, you're up to 15%. And we're seeing that in our clinic. People have recovered completely 2 or 3 times, and now we're coming in on the 4th. Like, this is not going away. Vaccination remains our most important tool of decreasing that risk. At the same time, as a public policy, the Omicron variants are not as dangerous as the original. People are not ending up in the hospital. There's a lot of immunity from either having the infection or having the primary vaccine series. And so I think the data supports that. That they are boosters. They are clearly helpful on a public policy level, but people can still get reinfected.
Sure.
And so I guess my opinion is for long COVID of like, yes, it works. We should not limit access, and they remain safe for the vast majority of people, and the adverse effects are rare. And so I think we should not limit access to these. But for someone who is very healthy, young, your risk is about 3%. That means also 90%, 97% chance you'll be okay. I think they should still have access to it. But is it like it was in the beginning where we need to mandate it? No. So I think there are some subtleties, but
sure.
I think that is also a hard conversation to have objectively and collaboratively, unfortunately.
Yeah, absolutely. It's, individual decision, but the 3% can happen. I know.
Yeah. And I'm like, it's not to downplay that risk.
Yeah,
I think the question is, what is the 97% of the people owe to the 3% of people? And that is just, there's so much toxicity around that conversation that it's hard to think about it in a truly what is a public health approach. Yeah,
absolutely. I don't know if you can say this, but how many people do you guys serve at this clinic? How many patients?
Yeah, we've seen, I think last number, 12 to 1,300 unique patients total.
Wow, from last...
total.
Okay, total. Yeah.
And so, we, that's about the total number of unique people we've been able to take care of.
Great. Yeah. So I guess zooming out a little bit, kind of working with long COVID, kind of the unique disease that it is, how has that changed your understanding of, both medicine, like as a doctor, and kind of chronic illnesses in general?
Yeah, I think it's been fascinating, and like this, of really changing my perspective of patients being the expert and listening to them. When I work in the hospital, very few patients want to talk about like, oh, did you read this new article about diabetic foot ulcers and how to treat them? But in long COVID, just how engaged people are, just their willingness to want to participate in research, ask really good questions, help define the illness. Really seeing that as like a partnership has really changed how I've approached medicine. I think also how I've communicated and just sometimes I've learned like just shut your mouth and listen. And how powerful that can be, especially when there's an illness with a lot of uncertainty or hard decisions. And yeah, I think sometimes it has made me disappointed in other doctors or clinicians who don't have that curiosity and don't want to take care of them. But I also think it's kind of driven me to want to continue to educate and expand the capacity and the science of long COVID too.
Yeah, definitely. So yeah, I mean, looking forward, you mentioned, the role that people and reinfection can worsen the risk and stuff. What do you see in the next several years as far as your expectations for long COVID or people coming down with long COVID?
Yeah, there's a few parts of that. Certainly I think the way it feels like it has been going extraordinarily slow, and patients feel the frustration. I feel that too. But at least in the cycles, you make some breakthroughs, you publish them. That takes about 2 years. Then everybody goes back and tries to build on that. Sure. So I'm hoping it's been a little bit of a lull, but we'll be at the end of the cycle of, that work building on prior work will come out and we'll really understand the biological, the cellular basis of this. I think we're starting these larger trials. It's been really slow. They have modest ambitions, but once we understand the science better, I think a lot of people will jump, and pharmaceutical companies will jump in this space. Maybe if you'll allow me to get on my soapbox for 1 second, I guess one thing in the future that really worries me and excites me is that we need biomarkers. We need a diagnostic test for long COVID, whether it's inflammation levels through cytokines, viral remnants, or microclots, or a panel of all of the above. And when we get that, that is going to be transformative because we'll be able to diagnose it, we'll be able to characterize it, and we'll be able to do clinical trial research that tracks whether that gets better when you give the treatment. I think on my soapbox is just to say like that is, I think, coming in the next couple of years, and that's going to be transformative. But I really worry about the people who do not test positive for the illness, and I think we got to start preparing for that day. The doctors, the researchers, and the patient community. Because think about it, if we have a blood test for long COVID, there are going to be people who don't test positive, and either they don't have long COVID, so they have something else, and we need to figure out what that is.
Right.
And I don't think the long COVID clinics should abandon them. But I also think we should help them get the appropriate care they need. And so we need to not exclude people from that. We need to be thinking about how we're going to help them with their complex health needs. And two, there's going to be people, no test is perfect, who don't test positive but still have long COVID. And I think we're going to have to say scientifically, you cannot participate in clinical trials because we can't measure your test. You may ruin our results. We need the clarity. But I still think we owe it to those patients to say, we're also not going to limit your access to these medications if they work in people with the test.
Sure.
And so that's going to be involving getting insurers involved, making sure a policy is still going to be able to treat them. And so I guess the biomarkers are going to be transformative it is going to exclude people, and I think and there's going to be some trade-offs in that, and I think it's coming, and we should all get ahead of that and have a plan for that, of how we're going to continue to treat these people, whether they fit that category or have that positive test or not.
Sure. Yeah, that's definitely, I can see why that would be a challenge, because I know a lot of the stuff that we talk about is, there's long COVID, and then there's so many other health conditions, chronic conditions, and they're kind of one and the same, at this point. The long COVID could present as any one of those diseases. You can have those and also have long COVID, or not have long COVID, but you feel the same at the end of the day. So I think that's great that you guys are, trying to balance that and see.
Yeah, and I think that inclusive approach right now is right on, but as we really try these experimental therapies, we're going to have to narrow it. And, I just think that should not come at the expense of people who are not doing well and need help. Yeah. So hopefully we'll start that conversation now.
Yeah, absolutely. So yeah, I mean, given obviously the impacts of long COVID, the impacts on individuals, and, a lot of people, they can't work. I don't know if you know statistics about how many of your patients have had to quit their jobs or et cetera, but I know a lot of our group has had to kind of abandon that, and even social life and stuff. What do you wish that, the general public or policymakers or even employers knew about the disease that maybe they're unaware of?
Yeah, I can't tell you how many disability letters I've written that just like, how do you explain post-exertional malaise? Yeah. And how fundamental that is to this illness of like, and most people, in America are not wired this way. They want to fight, they want to keep going, they want to push through, but that makes them feel worse. And like, that is clearly a documented phenomenon we can measure. And it's hard because it's like your word against mine, right. Or your word against your employers. But that's what the illness is. And so I spend so much time of being like, that is fundamental to the illness. This is a real physiologic phenomenon. And there's been some research of showing that like post-exertional malaise is associated with muscle damage. It's not a symptom. It is a disease state. And trying harder is going to make people worse. It's not a moral failing. And so I do think of us like, I beat that over and over of, I think some places are catching on. I've heard of patients being able to access disability benefits. I do think once there is a biomarker, that will certainly help. Absolutely. But it's kind of telling that story of, do you fit all these characteristics? How does it affect your life? It is not easy. And I think I'd have to go back to our data, but it is, I think it's about a third cannot work because of the severity of the illness, and about about half have had to reduce or change their position, just are not working in the same capacity. I would say it's actually very rare that people are experiencing long COVID and have had their work unaffected from it.
Definitely. Yeah, it's a big problem, and the scale is massive, as you said. So yeah, I guess kind of, to close out and, speak to the general audience here, which is long COVID patients or people who are, have a family member, friend, someone that they're caring for with long COVID. What advice would you have for them, whether they're going through it, whether they, maybe have a family member and they don't really understand what's happening to them, but they want to help and support them? What would be your advice to them?
Yeah, I do think it's always like validating it of like, this is an illness. The science is understanding it. We are every day understanding more about the illness. And I think the good clinical trials for targeted curative medications are coming slowly, but it's happening. I do think, I know this gets a little bit controversial, but I do offer the hope of like, I get to see people getting better. I've been doing this 5 years now. It is a significant portion of people who maybe don't get back to 100%, but over that course, as the inflammation decreases, they are experiencing a significant recovery. I don't want to say that is every single person, and I don't want to minimize the suffering of those people who are not getting better. But I think sometimes when you're out there on online communities, which are amazing sources of support, when people feel better, they stop joining those groups, but they still come to their appointments. And so I get the luxury of hearing the stories of people getting better. And so I do think, in a lot of ways, we're focused, targeted, curative treatments, but pacing, time, treating symptoms, it makes people feel better, and I get to see people get better. And so I think we're not where we want to be, but I'm still optimistic of what I'm seeing and hearing the stories. I mean, the other day, they were sick in March 2020. They dealt with this for 5 years. I'd like to say I cured them, but they turn the corner, they start feeling better. And I was kind of telling them, I think this is going to be chronic to permanent based on their severity. And I was delighted to be wrong. Wow. And so I don't want people to lose hope because I think those stories may be underappreciated out there.
Yeah, definitely.
And also not to minimize the people who are not, but.
Of course, but it is encouraging to know that, that progression can happen, even if it takes several years, and that hopefully with the treatments and the research that you guys are doing, that'll only, increase into the future, so.
Yeah, and I do think, and we're going to be tracking people long term, what are their outcomes, but I still think day to day, a lot of people are getting better, and I think that's encouraging.
Yeah, definitely. Thank you so much for taking the time. We really appreciate it.
Yeah, this was a pleasure. Thank you for doing this.
Awesome. Thank you.